Hello everyone, and thank you for joining this poster presentation. This poster is about a rapid survey we conducted in Uvira, Democratic Republic of the Congo last year, following extreme flooding events. Uvira is a town of approximately 280,000 inhabitants located within a cholera transmission hotspot on the shore of Lake Tanganyika, as you can see here on the map on the right. The London School of Hygiene and Tropical Medicine, LSHTM, has been working with local health authorities in Uvira for several years to document the impact of large-scale water supply infrastructure improvements on cholera and diarrheal diseases. In April 2020, Uvira was affected by extreme flooding, which caused the destruction of approximately 3,500 houses, displaced 80,000 people, and led to a 6-week interruption in the water supply service. So we sought to document how the flooding affected access to water, sanitation, hygiene, or wash services in Uvira, and also to gather information that would help us contextualize the cholera incidence data collected through clinical surveillance at the main cholera treatment center in Uvira. For this, we conducted a survey among 148 households in July 2020. And for the sake of time, I will invite you to look at the poster for more details on the methods. Moving on directly to results, the first takeaway from our survey was that it highlighted the scale of the flooding. We had about 1/3 of the households who reported being directly impacted by the flooding, and 1 in 4 who were hosting people displaced by the flooding at the time of the survey. In terms of water access, we found that almost half of the participants had changed water source due to the flooding. However, at the time of the survey, 3 months later, only 1 in 10 or 9% were using an emergency water supply as their main source. 40% of the respondents said they had not had drinking water in sufficient quantity for their households over the 2 weeks preceding the survey. And very few, 3% or 2%, 3 households, had received household water treatment or hand washing supplies in the month before the survey. It is highly possible that the survey occurred too late to capture the full scale of the WASH response that was deployed in the 45 days or so following the flooding. We had about 1 in 4 households that changed sanitation facility due to the flooding, and those were primarily among the respondents who were at temporary hosting sites or those from directly impacted area. Moving on now to cholera surveillance, you will see those graphs on the poster as well. The first one shows admissions to the main cholera treatment center and confirmation results between August 2019 and August 2020. The dark blue color represents confirmed cholera cases with confirmation done through rapid detection kits, Crystal VC. The time of the flooding and subsequent water supply interruption are indicated for reference. And it is striking that admissions remained low throughout this post-flooding period. We see an increase after the water service resumed, but when we compare it to data from previous years, and you see on the second graph a comparison of 2020 in orange with 10 previous years of surveillance, we find that the increase we observed in 2020 was well within the expected seasonal variability in Uvira. This absence of peak may reflect an effective rapid WASH response post-flooding, or it may also reflect other factors influencing care-seeking behavior, as this period overlapped with the COVID-19 pandemic and severe restrictions locally. We feel that this work also underlines the strength of pre-existing partnerships to enable the rapid mobilization of research and response teams. And I would like to acknowledge and thank all those involved in this survey, including our funders, the Veolia Foundation and French Agency for Development, as well as OXFAM and the Uvira Health Zone. Thank you very much, and please do not hesitate to get in touch with any questions.